Well, welcome back. This is a special session on gene therapy. Joining me are my esteemed colleagues. First is Dr. Stephen Bagley. He's an assistant professor at Penn, well known for his work in CAR T cells and cell-free DNA. Lovely paper showing correlations with imaging and histology. Also joining me is Dr. Natasha Sheybani. She's a senior scientist at the Focused Ultrasound Foundation, and she's also a postdoc at Stanford, and she's previously had interests in liquid biopsy, radiomics, and radiogenomics. And I believe Dr. Germano will be joining us as a panelist. Oh, we're back on. Okay, wonderful. Thank you, Isabelle. She's professor of neurosurgery at Mount Sinai and also the director of the Comprehensive Brain Tumor Program. She's a thought leader in the field of gliomas. So thank you for our panelists for joining us. I thought I would introduce three key questions here. And certainly panelists, as you feel you have the appropriate expertise and wish to chime in, please do so. And so I wanted to ask our panelists, do we think there is a compelling gene therapy strategy that should be prioritized for immediate implementation in glioblastoma patients? Dr. Bagley, Dr. Sheybani, Dr. Germano, any takers?
So go ahead, Isabelle. We're going to say something.
Isabelle, I think you're muted. Dr. Bagley, why don't you take it while Dr. Germano works out the technical glitch there?
Yeah, so I think it's a really kind of loaded question, and my short answer would be no. I don't think that there's any one gene therapy that's emerged here that is in some way head and shoulders above the rest. I think that, with the CAR T cell stuff, which we'll get to in a moment, I can form a bit of a more informed opinion there. But I think with gene therapy, I do not see one clear choice to kind of move ahead here.
Dr. Sheybani, you gave a beautiful talk that is archived on this particular webpage. Your thoughts on the issue?
I would tend to agree with Dr. Bagley. I mean, certainly from the standpoint purely of, FUS in combination with gene therapy, the literature is rather sparse at the moment. And so I don't think that from the standpoint of even what this discussion is about today, we have a clear winner necessarily that's emerged in the preclinical literature. I would tend to agree that in the CAR T space, there are a lot of interesting developments that we could potentially foresee as sort of being able to push forward in terms of thinking about combinations with FUS. But certainly I think there's a lot of work to be done, a lot more considerations to be made before we can really plant our flag in the ground in terms of where we should be leveraging FUS in the context of GBM gene therapy.
Since you both have brought up chimeric antigen receptors, there's a wide variety of them that are out there. So targeting a wide variety of different targets, IL-13, RA2, EGFR, EGFRV3, chlorotoxin, et cetera. Is there a particular, in your mind, priority that should be highlighted for potential implementation?
So I think that the priority right now should actually be on bivalent or multivalent approaches. I think that targeting one antigen in this disease is probably, even if all else goes well, which is a big ask, you're probably still going to have therapeutic failure. This is such a heterogeneous disease, and doing these trials is very difficult from that standpoint as well, because you are often looking in the recurrent population and you need to confirm that the antigen of interest is still there. So that means repeat surgery, repeat biopsy in many cases. And that is one potential area where focused ultrasound could help. If it ends up improving the yield of liquid biopsy techniques, one may be able to confirm, for example, EGFRV3 non-invasively. And that's still, not something that's clinically available, but I think is a longer term goal.
Can you guys hear me?
Yes, we can hear you. Thank you, Dr. Germano, for joining us. Did you have specific comments on the first query?
Yeah, on the first question, I think, Amy, perhaps gene addition is something that we can focus on. I think that what we have struggled, some of us, with gene delivery is really how to best deliver the gene, and looking at cell vectors. And perhaps what FUS can really help us is in opening up, in a way, a broader way to deliver those genes, so that some of the vectors that we have been stuck with historically might become even more historically, and we can move on with a different therapeutic delivery.
So I want to provide a very provocative question. Is GBM really the right disease in the context of gene therapy then? Given its heterogeneity, should we consider another type of CNS tumor as a priority for this particular type of program in the context of gene therapy? Something that is more homogeneous as opposed to the heterogeneity of glioblastoma.
So I think that IDH mutant gliomas would be one potential area there, because that's one mutation that at least early in the disease course tends to be conserved throughout the tumor, and I think we all think that if you can successfully target that immunotherapeutically, you may do a better job on the entire tumor, as opposed to a IDH wild type astrocytoma where that's a much larger ask.
And Amy, I agree that some of our trials fail because we are always too ambitious, and the disease is called multiforme. Mm-hmm. So I think that your idea and your leadership has been to try to narrow it down to something that is more tangible. So perhaps instead of calling this a glioblastoma trial to identify a subpopulation, and I think that the IDH mutant would be a good one, but there might be more genetic signatures that we can look into.
Is there a particular gene therapy or gene therapy strategy that stands out in your mind that is perhaps superior as far as adequate delivery? So the reason I bring this up is part of Dr. Sheybani's talk. She talked about nanoparticles. And one of the key limitations of nanoparticles is the fact that they are phagocytosed. So you have this competitive landscape in the tumor microenvironment with all these myeloid cells, all of these presumptive phagocytic cells. Is there another type, or should we highlight a particular type of gene therapy that may be more appropriate for glioblastoma over some of the other ones? Dr. Sheybani, would you like to comment, or Dr. Germano?
Yeah, I mean, I think that if we're thinking about this in the context of nanoparticle delivery, then certainly part of this question comes down to what non-viral vector formulations are out there. One of the ones that I highlighted that's already been explored in the context of GBM was this brain-penetrating nanoparticle formulation that Rich Price's group is exploring the use of in collaboration with Justin Haynes' group at Hopkins. And I think this is a pretty compelling approach in the sense that those particles are really optimized, and I use the term optimized loosely as an engineer. They are somewhat optimized to be able to traffic more effectively within the brain parenchyma, and also are known to have lower immunogenicity, to your point about these nanoparticles being phagocytosed. So I think that some of these questions might relate to what advances are sort of being made within the controlled release and nanotechnology domain if we were to go that route with combinations relating to FUS. But I would love to hear my fellow panelists' thoughts about this as well.
One of the strategies that was highlighted was the viral therapies. And there's many of them that are currently out in the neuro-oncology, neurosurgical field, wide variety of different types. Although they were initially devised to be gene therapies, they've really sort of have taken on a new life to be more of an immune modulatory strategy. Dr. Bagley, do you have a particular sort of thought as far as of the strategies that are currently out there, is there something that should be prioritized for blood-brain barrier opening ultrasound, and if so, why?
What I think is that if you choose any of the viral therapies being studied in glioblastoma, I think that across the board we see low response rates, but potentially durable responses. And I think that the ones that are not responding, a large part of the problem is the immunosuppressive microenvironment. And so the trials that are ongoing, looking at combinations, whether it's a PD-1 inhibitor or some other drug to alter the microenvironment in combination with these viral therapies, is what I find most interesting. And you can imagine a scenario where focused ultrasound is used not only to, sort of rev up the microenvironment from an immune standpoint, but also improve delivery of whatever partner drug you're giving. So again, maybe it's a TGF-beta inhibitor or an IDO inhibitor, one of these agents that may not have great brain penetration, but all of a sudden you're able to get better levels in the microenvironment and make a more meaningful impact.
Do you think it would be applicable to any of them, or are there some that would be more appropriate for?
Yeah, that's a good question. I don't know that there's one that strikes me as the most promising for out of all of those. I mean, I think there are only a few trials that are in combination with virus plus drug sort of trials. But PVS Ripo comes to mind as one of them with pembrolizumab, and so I think that setting would make sense to me. To try to really augment the limited responses we've seen so far.
Isabelle, as a thought leader in the field, do you think these need to be tested preclinically, or is there enough sort of clinical trial data and sort of the concept is sufficiently far along that we could move directly into clinical trials?
I would favor probably a phase 0. I think that that might give us the best possible real-time understanding of the disease. In the previous sessions and panels, we discussed a lot, we touched upon the fact that there aren't really very good GBM models at the present time. So I am a little bit skeptical in continuing to use such model, especially when immune therapy and immune modulation is coming along, because those models are even more limited. So I would favor what you just posed as a question, and that is that there is some preclinical data, and that the phase 0 might be more meaningful to us as a community than some more of the animal studies. But I'm interested also in what our other panelists' thoughts are.
Well, we do have a question from the audience. There was a question of, do we see a role for gene therapy in driving CAR T-cell responses? I'm presuming from the nature of the query that what they're talking about is delivering, let's say, an antigen or a target for the CAR T-cells first, and then followed by a CAR T-cell immunotherapeutic. If I've misinterpreted the question, my apologies to our participant, but would anyone like to comment on that, including possible feasibility issues?
Yeah, I can just comment from the feasibility standpoint. I think that, unfortunately, we're probably a long way away from that. I think just doing a CAR T-cell trial in human glioblastoma itself with just a single antigen CAR without anything else is already incredibly expensive, time-consuming, and we've learned that firsthand. The last couple of trials we've done at Penn, they take much longer than you think, are far more expensive than you think. And so I think we need to show that we're actually getting efficacy with CAR T cells alone before we start combining them with things. We haven't even really seen that yet, with the exception of a rare case report. So I think we're as much as we all want to push these things together quickly, I think we need to make sure things work in isolation, at least somewhat of a signal before we start combinations.
One of the things that's emerged in the literature to the point about the gene therapy and potentially providing a target to the CAR is the concept of tragocytosis, which is essentially where the CAR T cell strips the antigen off the tumor that we've seen in like the EGFR-V3 clinical trial. There are strategies that could potentially block tragocytosis or genetic modifications so that the antigen remains on the CAR, on the tumor, and the CAR can't access it and strip it off. Dr. Bagley, is your group considering any of that work?
Only in early lab experiments, actually, in other solid tumors, not something we've looked at in glioblastoma.
So, Dr. Sheybani, you talked about a variety of different types of gene therapies. We've got 2 minutes left. Was there one that stood out in your mind, coming back to sort of one of the key questions, since you did such a beautiful comprehensive analysis of this? Was there something that you thought, I'd really like to see that happen?
Well, I think that there are some really sort of cutting edge approaches that are being explored in the literature right now that take us in a totally different direction from how we're thinking about FUS in the present moment. Right now we're talking about leveraging focused ultrasound as a tool to potentiate greater delivery of immunotherapeutics or gene products to the tumor to modulate the immune system. But there are some really cool sort of next generation approaches, as I call them, where there are groups, notably at Caltech or UCSD, who are basically trying to leverage FUS as a remote control for CAR T cells, for instance. So, one of the outstanding issues with immunotherapies broadly is this sort of off-tumor, on-target toxicity issue. Mm-hmm. And I think it's really compelling to think about a way in which we could basically activate the CAR in the precise location that we need it. And there is some very early preclinical literature out there suggesting that non-invasively, we could leverage ultrasound as a tool for enabling this with engineered T cell products and certainly other cell types as well. I think we're going to see that frontier emerge within the FUS community as well in the coming years. So just off the top of my head, I think it's really compelling to think about those kinds of possibilities going forward as well.
That might be very applicable to things like the EGFR CARs that have not found their way into clinical trial for that specific reason that you've brought up.
And that really addresses a key limitation, which I think is important to think about here.
And the silencing too. I think that the silencing that you alluded in your beautiful presentation is something that we're just understanding. And I think that there might be some very nice focused ultrasounds application to leverage what we can do about that.
Well, I'd like to thank my panelists. Our time has drawn to a close very rapidly. I wanted to let the audience know that we're going to be taking a short break before we move to the next panel. And I thank you all for attending.